Hello, and welcome to the latest in our series of AI Med Talks. I'm Alexis May, Content Director at AI Med, and today I am joined by Dr. Sam Ward, a urologist based in Brussels in Belgium, Tom van der Putte, and Timoty Barclay of Bingli. Gentlemen, welcome.
Hi.
Today's discussion
Hello.
will focus on Bingli's work in Belgium and across the world to support diagnostics around COVID-19. To start us off, though, I'd be grateful if each panelist could introduce himself, please. Sam, perhaps we could start with you, please.
Thank you for inviting me. As you said, I'm first of all a physician and urologist in a hospital in the city center of Brussels, the heart of Europe. I'm also the manager of the surgical department, which includes more than 50 physicians, 10 residents, 250 nurses. I'm also the founder of an international NPO called BHCT, Building Healthcare for Tomorrow, where we try to bring different stakeholders together and create a more citizen-driven health, a new ecosystem.
Excellent, thank you. And Tom, could you introduce yourself, please?
Yeah, so my name is Tom van der Putte. I'm one of the two founders of Bingli. I guess we will go into more details about what Bingli is. So we created the company 3 years ago, but are already working on this project for 5 years now. Yeah.
And Timoty?
Hello, thank you for having us. My name is Timoty, and I'm a doctor/engineer, and I work for Bingli as their data scientist and developer.
Wonderful, thank you so much. And Tom, as you suggested, perhaps you could give a bit more of an overview of Bingli, please.
Yeah, so Bingli is a company that develops AI-powered chatbots to better prepare patients for medical consultations. So actually what we do is, by using artificial intelligence, we mimic the way doctors think, and we ask the majority of the doctor's questions ahead of the consultation. So we ask, on average, 70 to 100% of the doctor's anamnestic questions ahead of the consultation, so patients have time to think about the answers and go better prepared to the consultation, and doctors, they win valuable time because the majority of the information is already gathered. And based on the gathered information, we can trigger actions which can be clinical actions, red flags, triage actions, but also administrative actions or flows like, for example, you first have to go to radiology before going to an orthopedic surgeon. So can be many kinds of actions we trigger based on the information we gather. And maybe, so what we do is the way we interview the patient, because that's what we actually do via a chatbot, is based on differential diagnostic reasoning. So it's not a decision tree, it's really a model that mimics the way doctors think. So we ask a question, the patient answers, and with that answer, we calculate potential diagnosis, and immediately we calculate what is now the best next question to ask, which question does generate the best or the highest information gain. And that question is pushed to the patient answers with yes or no, and again, that data is again fed to the engine, and a new question is calculated. And we do that 10 times. So we calculate 10 questions.
Okay, that's great. Thanks, Tom. And how have you adapted your approach since the emergence of COVID-19?
Yeah, what I can say, but I think Timoty can explain better. But in a nutshell, our classical approach is differential diagnostics. So we calculate by interviewing the patient what are the most probable diagnoses given the input of the patient. Here for COVID, we work more in a diagnostic way. So we want to calculate the probability of a COVID-19 infection. But maybe, Timoty, you can explain a bit more.
Yeah, so we had to completely restructure our engine that does the prediction, because now we're not working with a whole lot of diseases, we just work with COVID. And we were looking at how it was done in a clinical setting. So the first thing we noticed that the decision trees that were often provided to doctors were often lacking. They usually always say, "You doctor, use your common sense in the end." And of course, when you create an online triage system, you cannot do such a thing. The computer cannot use its common sense. We have to immediately modulate it. And we then started looking into other models to use. One of them being the many-valued logic model, which we then used. In the beginning, we had a lot of problems with not having enough data because there was not enough at hand. We were still having no patients in Belgium, so of course we cannot use them. But what we could do is say, we have a patient of around 60 years old. Is it a high-risk patient or not? Well, it's between 0 and 1, and we incorporated that into our model.
Okay, that's excellent. Thank you. And Sam, I understand that you have Bingli in deployment where you're working. What sort of impact are you seeing on the ground?
So the lockdown in Belgium started, on a weekend day, the 14th of March. And we were quickly overwhelmed by the calls of patients and worried civilians about their health status. So they called the hospital, and you have to know that in a weekend day, there is not that much personnel there. So they tried to contact their general practitioner, and we know that on an average, a general practitioner has 3,000 patients he follows up during the year. If this GP would have had to answer only 5 minutes every patient, that would have been 15,000 minutes, 250 hours, or 10 days non-stop of phone answering the phone, just to reassure patients more of the time. So we were all overwhelmed, and we didn't have a lot of time to react to or give answers to everyone, so we needed help. And of course, we had a good relationship with Tom and Alexis and William from Bingli, and they immediately were there to assist us and manage our time in a better way. So that's how we implemented this on our website. So the first thing that happened is that we gained much more time for the actual help we needed to give to the COVID patients. Second thing is that it helped us strengthening the relationship with a lot of general practitioners that were also overwhelmed by phone calls, and we contacted them, and they could readdress their patients to the triage module to know if they had to come to the emergency department or not. So that was a second big help. And of course, now in the next few weeks, we will gather all this data that we recorded, and this will be able to help us in the future to deploy our resources in a better way.
Yeah, and I mean, it's been said a lot in recent weeks that, while it's an incredibly challenging time with regard to digital remote healthcare solutions, it's actually accelerated deployment, which has, for some reason stalled previously. This to all of you, I guess, what do you think? I know it's difficult to predict at the moment, but what might the new normal look like in terms of digital versus face-to-face healthcare when we get there?
To whom?
Well, I'd love to get all of your perspectives on that.
I can start.
You first.
You have to know that in Belgium, a lot of physicians that are active in the medtech industry that are helping to develop such tools were blocked by law, were prevented to implement telehealthcare. So only last year in September, there was a small opening of the Chamber of Physicians to try to begin to analyze if telehealth could be a solution. And a lot of physicians and other healthcare professionals were very skeptic about telehealth. And also a lot of civilians and patients were very skeptic about it. So now that this pandemic came all of a sudden, it opened up the eyes of many colleagues and also patients and civilians that we could really, citizens, that we could really use this as a tool, not only for healthcare, but also for work out of their homes.
Yeah. I think to complete on that, indeed, I think that now civilians and physicians, they will experience in real life and in the facts how easy it is to use digital solutions to improve healthcare and how it will evolve. So I think that some barriers will fall. So some misconceptions will fall. But what is important is that we have to keep the power of physical consultations if needed. But we see now that there's a capacity problem, and I think from our country in Belgium, we are still lucky to have enough nurses and doctors, but we know that in many countries it's not the case, and in the future it will be less the case. So there will be a big shortage of resources, human resources, to have physical consultations. So we need to be very efficient in how we use that. And I think that digital solutions can better triage patients who need a physical meeting, a face-to-face meeting, in order to better use the capacity that is available.
Sure. I mean, we've also got that appetizing opportunity, and you spoke to this a little bit, Sam. If you're doing things digitally, you're automatically capturing data. Where if you're attending a general practice surgery and they're still taking handwritten notes, or in some cases that is still happening. What do you see? Well, I mean, in the context of the data that we're potentially collecting through your solution, how that might that contribute to more generally to healthcare, and how we plan and manage that going forward is a kind of bigger picture thing. Sam, any perspective on that?
Well, first of all, managing our time has always been a challenge. Even before the Corona crisis, we're talking about work-life balance and how to maximize the time we can use at work. And structuring teleconsultations with a tool like Bingli is helping us a lot. First of all, like you say, to collect data, but that's more the second thing. But first of all, to help structurize the time and to gain time by having the answers of most of the questions we will ask them anyway. So this helps us really to manage our time and to be able to see more patients. Even if they need a pit stop, they can use this tool, and the efficiency of our work will be much higher.
Okay, Tom, Timothy, any comments on that?
Also in different departments, so if you go to the emergency ward and you arrive there and you have to wait until you see the physician, first of all, there will be a triage by a nurse. This can also help our healthcare professionals to work in a more similar way, in a more efficient way, to ask the same questions to everyone, to direct more specific questions depending on the symptoms they relate to. And this is very important, that standardization will get efficient and more effective if we use these kind of tools. Even if the healthcare provider uses the tool toward the patient, or if the patient fills it in on its own waiting in the waiting room.
Okay, Timothy, you had a point to make.
Yeah, so as a data scientist in the medical field, I'm used to working with a lot of messy data and data that's unknown, and working with tools as this is actually quite a relief, because we have data that's completely clean in the end. There's no missings, everything's filled in. Yeah, it's actually a lot nicer to work with in the end.
Yeah, so what we saw is that especially in the field where we are active, which is the anamnesis, so it's before the diagnosis, there is no qualitative data, because doctors, they don't code or structure anamnestic information. So as Timoty says, there's a lot of crappy and inequality, messy information. So we are structuring that, and it's actually the patient who's doing the effort, because by doing the interview in Bingli, by doing the anamnesis, we structure the data at the source, at the data collection point. So we use SNOMED-CT as a basis, but we can translate to ICD-10 or ICPC-2. And the extra advantage is that as we have structured and qualitative data, the doctor can easily validate that data and import it in the EHR. So this wins on top of the anamnestic time we win. We also win a lot of time in administration, which is, of course, as we all know, a major reason for burnouts and a major reason for time loss and money loss in hospitals and in doctors' offices.
Yeah, indeed. Well, sorry, Sam, go on.
Add something on that. Me as a physician working in the city center of Brussels, we have a lot of foreign people. They don't always speak the Belgian languages. They don't always speak English. And with these kinds of tools, we can ask the questions in their own language. And with the referenced answers, we can interpret them in our own language. So this helps to relieve a barrier that we have between some patients, which is very interesting.
Thank you all. And I mean, just to dig into that final point about the data and how you're able to deliver that kind of structured data through the tool you've developed. There's quite a lot of talk, any conversation around AI in healthcare comes back to the data and the potential of artificial intelligence in medicine is to democratize healthcare in a really significant way. What are your takes? And this might be to you, Timoty. Sam, Tom, you might have views on this as well. What do we need to do? And what's happening right now does open up some of these conversations in order to establish some standards around how this data is structured, so that it is interoperable. Regardless of which EHR you're using, or what different solution you're using. What would a starting point for a conversation about that standardization look like? Timoty, for you, I guess.
I would say SNOMED-CT immediately. If everyone started using it on a general basis, everyone else can use it. So I don't think there will be a problem in the end, but it's not being used correctly at the moment, and that is the major problem, I think.
And on top of that, I think there's also, so that's the language, let's say, but then there's also the protocols to share data like FHIR or HL7, which are beginning to be adopted, but then we all know that many let's say innovative companies like Bingli, they do all the effort to adopt SNOMED-CT, ICPC2, ICD-10, FHIR, HL7, all these kind of buzzwords. But then on the other hand, the EHR has to open up and accept that data to come in. And that's often not happening yet, at least in Europe. I think in the US it's a bit more open, a bit more evolved in interoperability standards, but in Europe we see that it's still it still has to happen. And I hope that this Corona moment will be a catalyzer to open up these closed systems.
Yes, indeed. Right. Thank you all so much for taking the time to join us today. It's greatly appreciated, and congratulations on the excellent work that you're all doing. And thanks to everyone for joining us. Please keep an eye out for more AI Med talks at www.ai-med.io. Thank you.
Thank you.